Well, good afternoon and welcome to this ERKNet webinar. There are currently at least 35 computers that are attending these webinars and many more people listening. My name is Francesco Emma and I'm speaking from my office in Rome. So before starting, I guess most of you are by now familiar with the system, but for those of you who are not, let me simply remind you that your microphones are turned off, so you cannot ask directly questions. But during and after the webinar, you can send your question through the application that is present on your screen, on the right-hand side of your screen. And I will ask your question at the end of the presentation. The webinar will last approximately 30 to 40 minutes, and we will have approximately 15 minutes available for question at the end of the webinar. Should there be not enough time to address all your questions, they will be forwarded to our speaker today, which is Professor Rukshana Shroff from London. So Rukshana is a consultant in pediatric nephrology at Great Ormond Street Hospital for Children in London, and also an academic position in nephrology as associate professor at University College of London. Her research focuses on cardiovascular diseases in children in childhood chronic kidney disease, and that includes laboratory works, clinical research studies, and clinical trials. She is the PI on a multi-center study comparing long-term outcome of conventional hemodialysis and hemodiafiltration in children. She currently holds a prestigious senior fellowship from the National Institute of Health Research to continue research into mineral dysregulation in CKD. She has published more than 130 original articles, reviews, and book chapters in the fields of nephrology and dialysis. Dr. Shroff is in the executive committee for KDIGO, and she has served on the recent KDIGO CKD MBD guidelines update groups and on 2 NICE guidelines committee. She is currently an associate editor for pediatric nephrology and serves on the editorial board of Clinical Journal of American Society of Nephrology and Peritoneal Dialysis International. And she leads the CKD dialysis working group of the ERKNet. The title of her talk today is Nutritional Management in CKD. Thank you, Rukshana.
Thank you very much, Francesco, for your generous introduction, and welcome, friends. I hope you can all hear me clearly. It feels a bit strange giving a talk sitting in your office in front of a computer, but what I would very much like to do is keep this as an interactive session, and we can go through some questions and answers as we go along. So the growth failure in chronic kidney disease is certainly multifactorial, and there are a large number of factors that will impinge on growth and cause growth failure. These can include genetic syndromes, including the primary renal diagnoses, IUGR, and the parental height itself. It also includes malnutrition, including catabolism and inflammation, as well as factors such as metabolic acidosis, renal anemia, the fluid and electrolyte losses, renal osteodystrophy, and hormonal disturbances as well, which include not just growth hormone, but also the gonadotrophic hormones and steroid treatment as well. So with all of these different factors, children with CKD are more often than not growth stunted. So let's consider what we need to do about this. So first of all, unlike this beautiful little boy in this photo, not all our patients are nice, big, chubby children. And we need to ask ourselves, why should we bother about growth failure in CKD? Does it matter? Is it just a cosmetic thing? Or is it actually a quite major organic problem? The second thing to talk about is enteral feeding, the importance of this, and also a little bit about gastrostomy insertion. Can I just, Francesco, can you hear me?
Yes, I can hear you.
Is the broadcast, yes. My screen still says start broadcast, so I'm just confirming it is on, yeah, for everyone?
We are listening you well, okay. and we can see your screen.
Okay, no, as long as it's on. Thank you. Thank you. Sorry, everyone. So just to carry on then, so we'll talk about gastrostomy feeding and issues with that. And then what I'd like to do is a case study. And during the course of that case study, also talk about what the guidelines recommend, basically the KDOKI nutritional guideline. So why focus on nutrition? Now, the energy cost of growth, that means the amount of energy a person consumes that is used in growing, is extremely high for the first month of life, as much as 35%, and then it slows down as the person gets older. But growth velocity itself is a very sensitive indicator of the energy status. In addition, serum albumin has been shown to be a strong predictor of clinical outcome in children on dialysis. Now, albumin, of course, is also an acute phase reactant, so we've got to keep that in mind and think about inflammation as part of this whole spectrum as well. And then short stature has been shown to be a mark of a poor outcome, and that can be a multifactorial issue. But as said by one of our very renowned and experienced nephrologists from the UK, the dialysis is easy. It's the feeding that is difficult. And this is indeed what I see often in my practice. So the phases of growth. Now, in this graph here, you see that there are 4 different phases of growth, from the fetal life to infantile, childhood, and puberty. And even by the end of the infantile phase, approximately 50% of final adult height is reached. So this is a very, very crucial phase of growth, depending entirely on nutrition. Importantly, the calories that are used to grow and to develop new tissue is extremely high in the first 6 months and remains quite high for the first year of life. What you will see in this graph, and this is quite an old paper from the 70s, but very interestingly, you see that when more than 80% of the dietary requirement of energy is provided, the growth velocity is adequate. That's what you see on the x-axis over here. However, if the energy intake reduces below 80%, and certainly when it drops below 40%, all growth can stop. And this is, although an old study, a very, very important important one for us to keep in mind in our practice as well. Now, causes of poor nutritional intake are plenty, and certainly many, many more than I've listed on the slide. But in children with CKD, they can have a poor appetite for many reasons. They can have vomiting, which sadly we see very, very commonly and is difficult to control and very distressing for the families. And then there's a disturbed feeding history, especially in the premature babies or babies who had CKD from birth. And of course, complications with comorbidity. In addition to this, on dialysis, there can be fluid restrictions, the dialysate loss of proteins and sodium, and peritoneal dialysis itself can cause the sensation of a full abdomen and constipation, and the child doesn't want to eat. Now, there are multiple causes for the abnormal GI motility, which can cause vomiting, and the appetite control. And if we look at the hormones that regulate this, there's more and more research looking at different hormones such as cholecystokinin, gastrin, leptin, and ghrelin, which play a key role in all of us in our appetite regulation, but very much so in CKD patients can be dysregulated. These are large or middle molecule size compounds, which are very difficult to clear on PD and even on conventional hemodialysis. So looking at this data from the IPPN registry, here they've looked at infants under 2 years of age and the different modes of feeding them. So you see that in blue, the majority of a large number of children in the US and certainly some in Europe are on gastrostomy feeding. And whereas the percentage of gastrostomy or NG feeding is significantly lower in other parts of the world. Now, it's not just the tube you use, it's what you do with that tube, of course, and how effective it is. And we look at the different aspects of this. But advantages of gastrostomy feeding are certainly very high. It includes an improvement in vomiting and appetite regulation and the nutrition and growth of the child. It doesn't interfere with the child's oromotor skills. because it's hidden under the clothes, it's not visual, and it doesn't distress the child or the parents with it. And then, of course, there's the ease of administration of medications and fluids down this tube. Now, the same IPPN study that I mentioned just a minute ago looked at the growth in children depending on the percentage of time that gastrostomy feeding was used. And looking at the height standard deviation score, comparing with children who were on demand feed, so just oral feeding, versus those who had NG tube feeding and gastrostomy feeding, you can see that the height standard deviation score is certainly the least affected in gastrostomy fed children. Here you'll see a number of tubes, which I'm sure you're familiar with, ranging from the PEG or the percutaneous endoscopic gastrostomy on the left, and the Mickey button. But the giveaway here is the surgical scar you see in the supraumbilical area, which tells you that this is an open gastrostomy. Now, this slide may be a little bit misleading, but just to clarify, when we do an open gastrostomy, the first tube that's put into the stomach is a Malico catheter, and only a few months later, as in probably 2 to 3 months later, it is replaced with this Mickey button. Now, the gastrostomy placement can be an open surgical procedure, or it could be a percutaneous endoscopic procedure. For the percutaneous procedure, it could be done by a surgical team where an endoscopy or a laparoscopy is performed, or like in my center, it is done by interventional radiologists who have the added advantage that they have a fluoroscopically guided procedure to know that they're exactly in the stomach and the colon is moved out of the way. A very, very important factor is that percutaneous insertion of a tube is a blind procedure. And during a blind procedure, there's a high risk of spillage of the gastric contents into the peritoneal cavity. And this can be a very high risk process, especially in patients on PD, of course. So the timing of gastrostomy insertion in a child on PD needs to be very carefully thought through. And it could be, of course, done before the PD catheter is inserted or at the same time as the PD catheter, and then after starting PD. So what are the issues with putting in a gastrostomy after starting PD? And there are 3 studies from 3 parts of the world that have looked at this. And what they have seen is an extremely high incidence of peritonitis, particularly so of fungal peritonitis, and children actually losing their peritoneum from severe infections, including 2 deaths in the first study. So, because of the gastric spillage of contents into the peritoneal cavity, this a endoscopic procedure is not to be performed. And KDOKI in their guideline have clearly stressed this, saying, as you will see in the bold letters, an open gastrostomy can be performed safely in children on PD and with suitable precautions. The precautions that they're talking about are antibiotic cover and antifungal cover to be safe. So moving on now, what I'd like to do is a case-based discussion, and we'll follow this little child from his birth and infancy with a few different scenarios. What I've done is add in the recommendations, the guideline recommendations, as we go along discussing each scenario. So to start, we have a male infant with posterior urethral valves and dysplastic kidneys. He was born at 38 weeks with a low birth weight of 2.1 kilos, and his length and head circumference were on the 2nd centile. Fortunately, he did not need any respiratory support. And after coming to our ward, he's catheterized as you would routinely do, and he has a urine output of between 2 to 3 mils per kilo per hour. Now, in terms of this baby's feeding, what shall we do? So what I've done here is provide a list of different options. And of course, because I can't see you and you can't see me, an interaction is going to be a little bit difficult, but we can look at different options, and you'll certainly have these slides to look at later. So from this list of options, hopefully none of you would want to keep this baby nil by mouth. nor would you want to put them on just clear fluids or IV fluids. But I'm sure that what most of us would do is to actually encourage breastfeeding if that is what, if the mother wants to breastfeed the baby. And if she does not want to breastfeed, then to talk about formula feeds for this child. So here what we would do in my practice is to support the mother in the breastfeeding, and usually we start whey-based infant formulas. The baby needs 2 to 3 hourly feeds in order to maintain adequate growth. And in many cases, intake from breastfeeding alone is not enough. And then what we have to do is to start a supplementary bottle feed. The energy requirements for the baby at this stage of their life need to be considered as well. And what we would do is, as per the KDOKI guidelines, we would provide 100% of the estimated energy requirement for the child's chronological age. And throughout CKD management and at different ages of children as well, as you see, I've put it all on the slide here. The estimated energy requirements can be provided, and sometimes a little bit more. But certainly you don't have to provide an excess amount of energy for any reason. The requirements, of course, as the child grows older, have to be adjusted based on their physical activity and their body size. Okay. Now, a very, very important factor in practical management is that these babies with CKD, these infants, have to be seen very, very frequently. And the reason for this is their weight gain is going to be about 200 grams per week on a normal level. So a normal infant of that age would grow by 200 grams each week. And so in a clinical situation, if the weight were to increase, say from 3.5 to 3.9 kilos over 2 weeks, then the protein requirement increases, the calories increase, and the volume of the feed increases. Now, if you did not see these patients every 2 weeks, but you, for example, left it for a monthly review, you would immediately fall behind in your provision of energy, protein, and volume of feed. And that means that you'll have a negative effect on the child's growth. So very, very regular reviews and keeping up with the feed intake is extremely important. KDOKI have expressed this similarly, of course, and suggested the frequency of visits in months for children of different ages and different CKD stages. Okay, so coming back to our patient, our little boy is now 5 days old. You can see the calcium levels are a bit low. The phosphate is just marginally raised for an infant of that age. The PTH is of course high. The upper limit of normal for these units would be about 6 picomoles per liter. There's a high alkaline phosphatase, and our dietitian tells us that the calcium intake and the vitamin D intake is on the low side. So what do we do at this stage? Do we just give calcium supplements? Should we restrict phosphate? Should we give 25 hydroxyvitamin D or 125 dihydroxyvitamin D? Or should we give a phosphate binder like calcium carbonate or calcium acetate? And hopefully, I'm going to say from the start, nobody will want to give an infant sevelamer. So in terms of what I would do in my practice is to start 25 hydroxyvitamin D supplement, because this baby is clearly has a low intake of that, and also give calcium carbonate or calcium acetate. And the reasons for this are that the calcium requirements and the calcium balance is very high in the first year of life, as high as 500 to 600 grams per day, and higher than any other phase of growth or any other phase of a period of development. You will see on the little graph in the right-hand corner that the normal serum calcium levels in an infant are much higher than those in older children. And it takes up to 4 years of age before the normal calcium levels come into the same range as that for older children. Also, we do not really know how much calcium is absorbed from the calcium-containing phosphate binders, but it is clear that whatever is absorbed at this early stage of life is actually quite important and required by the child. Looking at the KDIGO guidelines, now the previous guidelines you'll remember were from KDOKI, and those were based from 2008. KDIGO have updated their recent guidelines, and these guidelines have come out in 2017 as the updated CKD-MBD guidelines. One of the most important things in these guidelines is that KDIGO recognize the need for higher calcium requirements, especially in growing children, and therefore they suggest that the calcium levels are maintained in the age-appropriate normal range. And that the choice of phosphate binder is based on serum calcium levels. There are very few studies in adults, and therefore these recommendations are not graded, or have a low grade, but it's still very, very important to remember that a growing child needs calcium. In addition, for calcitriol and vitamin D analogs, again, the whole recommendation hinges on serum calcium levels and the need to manage this based on serum calcium. Okay, so calcium is one thing. With phosphate levels, now some of you will remember this graph again from the IPPN registry. The bar on your left hand side shows the serum phosphate levels in the entire pediatric cohort. But if you look at the subsequent columns, you see that at different ages, the percentage of patients, PD patients who have hyperphosphatemia varies. And it varies from as little as 6% in infants to as high as 81% in adolescents. And of course, phosphate management, as you all know in your practice, can be extremely challenging. So looking at this, at the KDIGO guidelines again, they say that in children with CKD stages 3 to 5D, the treatment should be based on serial assessment of calcium phosphate and PTH. So don't go by a single reading, go by the trend in the readings. Also, there's suggestion that there's a recommendation, the next recommendation is to elevated phosphate levels towards the normal range. Now, again, this guideline has a very low grade, and that's because KDIGO, of course, look for extremely high level and very rigorous, robust evidence, which sadly we do not have. But it doesn't mean that this is not an important recommendation. And certainly in my practice, I would very, very much follow keeping phosphate towards the normal range. The more we learn about phosphate, the more we are learning that other sources of phosphate need to be considered, particularly preservatives, additives, and processed foods that may be very high in phosphate. Okay, and finally, some of you may have seen the vitamin D recommendation that we produce for native and active vitamin D therapy through the ESPN working group. And this is, although not based so strictly on evidence like the KDOKI guideline, we've tried to be very comprehensive and give every aspect of vitamin D treatment in children that we can think of. Okay, so coming back to our patient now, the child is growing a bit older. His weight and blood pressure are increasing, but his urine output starts to drop. He has edema, and as you see the blood results below, they are beginning to deteriorate. So the child is becoming hyponatremic, hyperkalemic, becoming acidotic. The urea is increasing, the phosphate is increasing, and of course the creatinine, and he remains hypocalcemic. So at this stage, what would you do? Would you change all his feed to a low electrolyte formula, or substitute part of that feed with a whey-based formula and a low electrolyte? Would you add in vitamins? Would you start dialysis? Or would you do many of these different things? And in my practice, what I would do is substitute some of that whey-based formula with a low electrolyte formula and also start dialysis. So what I would be considering here is essentially the rising creatinine in this child, and the fact that we would need to move on with dialysis in order also to control this hyponatremia. So the weight is, remember, the child's weight is increasing and their sodium is dropping. in keeping with a low urine output. So they're basically retaining fluid, and the only way to treat this really would be with dialysis. Okay, so as we move on with the child now, there's lots of information on this slide, but importantly, you will see that we're now on dialysis with 16 hours of dialysis established for this patient. But here you'll see that their sodium level has corrected on a sodium supplement of 1 millimole per kilo per day, per kilo twice a day. And you will also note that the child has a low albumin level. So now at this stage, what next? Would you increase the dialysis, change the medicines, increase the protein or calorie content of the feed, concentrate the feed, start vitamin and mineral supplements, or start growth hormone? And quite likely do a combination of different things. And the combination of things that I would consider are to increase the protein and calorie content of the feed, to concentrate the feed, and to add in a vitamin supplement. So let's look at this. So essentially here, we aim for urea levels less than 20 and a normal serum albumin and normal growth. And in this baby, what increasing the energy and actually also increasing the protein is important, because there's a transperitoneal protein loss. And often it is the loss of protein coupled with the loss of sodium that you see in little babies. And here in this table on the left hand side column, we worked out the concentration of the feed and the volume of the feed that you need to give. So you may need to obviously do this in a stepwise way, increasing the calorie requirements. The protein intake also needs to be thought through quite carefully. And what KDOQI have recommended in their guideline is that in CKD stage 3, and 3, the dietary protein requirement should be between 100 to 140% of the recommendation in healthy people, or the DRI. As you progress to higher stages of CKD, and certainly on dialysis, an increased amount of protein is required, and increasing somewhat in HD patients, but increasing it significantly more in PD patients, again depending on the child's age and to compensate for the peritoneal protein losses. So KDOQI have provided these tables at different ages and different requirements for protein intake. Remember, the amount of protein you give has to be titrated against the urea level in the patient, and you aim to keep the urea level below 20, certainly in the younger children, sometimes a little bit higher than that, up to the 30s even, in a chronic older PD patient, provided they're completely asymptomatic. So moving on, the modifications of feed that might be required would be starting from the standard infant formula. We can add in protein powder, we can add in Vitajoule or glucose polymer, and again this will depend on the available preparations in each center, and of course the specifications for the child. If you look at the vitamin requirements for children, again, this is an important thing, because vitamin A accumulates in renal failure. It is exclusively renally excreted and cannot be removed on hemodialysis even. And so vitamin A supplements must not be prescribed to these children. Water-soluble vitamins, on the other hand, can be lost in dialysate. We know very, very little about these, and very few studies have been done in this field. We, in our practice with using HDF and using home dialysis, as in long hours of dialysis, have not seen any patients who have deficiencies of vitamins, but many foods are now fortified with vitamins. Certainly all the renal feeds are fortified, and that is probably what is keeping these patients safe. So coming back to the story, the baby initially does well on dialysis, but then begins to vomit, and the weight gain stops. The potassium and urea increase. The dialysis parameters are all optimized, and concentrating the feed has not helped. So what next? Shall we try and concentrate the feed even further? Or shall we try a continuous feed through a feeding pump with some overnight feed as well, and then some boluses in the daytime? Or shall we try medications like prokinetic agents like erythromycin, antacid drugs, or HT3 receptor antagonists? And I would probably do a combination of just slowing down the rate of the feeding, as well as introducing these prokinetic agents to try and reduce or stop the vomiting. Right. So the baby continues to vomit. Sorry, these are the challenges we face every day. Continues to vomit and the weight is still static. He's on this continuous feed. The feed is maximally concentrated based on what this child can tolerate, and the medications with the place now, and we have optimized his dialysis. So what next? We could try TPN. We could arrange a percutaneous gastrostomy, or we could arrange a surgically placed gastrostomy. And there is only one right answer here, and that is to do a surgically placed gastrostomy. Hopefully, none of you would want to try TPN. It would be a bad idea. And TPN, frankly, comes with far more risk than benefit, and in very, very few cases, really severely multimorbid patients, I would have thought about that, but not otherwise. And secondly, I've told you in detail why a percutaneous gastrostomy in a PD patient must never be done. And so we would do a surgically placed gastrostomy in these patients, which kind of brings us full circle to the start of the talk, or the early part of the talk, where so many of these patients need gastrostomy feeding. And certainly in our practice at Great Ormond Street, looking at children under 2 years of age, about 40% of those children have needed gastrostomies. We rarely need to do Nissen fundoplication, and it's really maybe one a year or even less than that in our practice, and it is more likely than not required in patients who have severe learning difficulties, or the very premature patients, babies who could have hiatus hernia as well. And so to conclude, a careful attention to nutritional requirements and early intervention is critical to prevent malnutrition rather than to treat it. An input from a pediatric renal dietitian is absolutely essential. For all of our severe CKD or dialysis clinics, we have a dietitian as part of our team, and very much a partnership rather through all of the clinic visits and all of the advice the family gets. Enteral feeding will improve growth in many, if not maybe most, children on dialysis. Once again, just that cautionary word about gastrostomy placement. So whenever you can plan the gastrostomy before the PD catheter, or otherwise do a surgically placed gastrostomy. And protein requirements increase in children on PD and must be frequently monitored. So thank you all very much for listening. What I should just add at this stage is to tell you also about a renal nutrition task force that we have set up initially through the ESPN, CKD and dialysis work groups, but the Americans got very interested and they've joined us in this initiative as well. Our role as the task force is to develop guidelines, and we have our guideline development meetings with dietitians, renal nurses and doctors together, and we hope to come up with at least 2 guidelines a year. So thank you again, and I'm told to inform you that the next webinar will be in 2 weeks' time on the 17th of April with Professor Muller talking on von Hippel-Lindau syndrome. Thank you.
Well, thank you very, very much, Rukshana, for this wonderful talk. I think this really summarizes our current knowledge, and this practical approach that you gave us, I think, was very useful for many of us. So please send in your questions, and I see that they're coming. So first of all, there are people that are just saying thank you. And that's Dr. Gondra Sangronitz, and I apologize if I didn't pronounce well the name. And he or she also asked a question whether, in your opinion, it is appropriate in some cases to use growth hormone before the first year of life if you don't have good growth.
That is a good question. And yes, there is a possibility that you might need to use it. I am not against using growth hormone, but what I would always do in my practice is to ensure that that the calorie and protein energy requirements are first and foremost met. And once you have ensured adequate calorie intake and you've excluded other factors such as, for example, very high PTH levels that will be counter effective to growth hormone, then I would consider growth hormone therapy. But nutrition has to be optimized first.
Thank you, Rukshana.
Yeah.
Let me ask you a question while other question will come in. I'm curious about the placements of gastrostomy in patient on peritoneal dialysis. So, on practical terms, how do you proceed? Because I agree with you that the risk of infection is really very high. So, how once you have surgically put the gastrostomy, how long do you wait before using it?
That is a very good point. So, what we were in the planning of it, what we would try and do is, as far as possible, if a patient has presented early, we try to preempt the need for the gastrostomy and the PD catheter, and try to plan the surgery. So we have at least 1 week between gastrostomy placement and then PD catheter insertion. Of course, this is not always possible. And then in that situation, we will try and do both PD catheter and gastrostomy at the same sitting. And if that can be done under adequate antibiotic cover and antifungal cover, that can be safe. And we can start using the tube even as soon as 6 hours post insertion, the gastrostomy tube within 6 hours post insertion. So that is a possibility.
Okay, thank you. So next question comes from Kuwait, and Dr. Bassam Sayed is asking you if you still don't have adequate nutrition parameters while on PD, could transplantation be a justified solution in infant?
That is an interesting question, of course. So, we always want our patients to go in for transplant in the most optimal condition. But there are patients everywhere in the world where you struggle with them, where the feeding is just not working despite every effort. Uh, As long as the patient is not severely malnourished, certainly not with protein energy malnutrition, um, and certainly after all attempts at other things have been tried, and also provided that the bones are not in a state of severe osteodystrophy, then yes, I would not hold back a transplant. I think there can be only, you know, we can only justifiably deny a transplant only in very, very few situations. And if there is extremely severe osteodystrophy, if the child is severely cachectic, then I would be careful in that situation. But otherwise, yes, I would promote a gastrostomy insertion. No, sorry, I'm going mad. I would promote a transplantation. Sorry.
Yes, but I think I'm not sure I interpreted this question well. The idea could also be how how soon would you do this? If you have a very young child, we wait more kilograms before ideally promoting a transplant. Now, sometimes you would decrease this threshold. How low would you give in a child which is not growing? Would you because we all know that the earlier, the higher the risk of a transplant failure for thrombosis. So what
Yes.
would be your limit?
So sorry, I did misinterpret that. Sorry. So in those terms, then I think what we do in our center is aim for a 10-kilogram child as a safe threshold for transplantation. Now, of course, you want a child who's 10 kilos and not just a big round ball, but 10 kilos and actually also growing long, growing taller. Um, so this depends very, very much on surgical expertise in each center, on any other comorbidities this patient can have, and the overall picture in this child. You know, for example, if somebody is struggling with dialysis access, if you're using up more and more blood vessels with hemolines, then the balance needs to be thought through. And the single most important factor in this is the expertise of the surgical team involved.
Mhm. I must say, Rukshana, I completely agree with you. And I would
Mhm.
say that I would still keep pushing. My indication for earlier transplantation is the dialysis access more than the problem of feeding. I would still keep pushing with the feeds, but it's really
Right.
the lack of dialysis access that sometimes make you really decrease your threshold for transplantation, at least in my experience. But I think we share the
Yeah.
same opinion. So we have
Yeah.
Dr. Menkay Yadav is thanking you for your excellent talk, and just had a query on how frequently do you face the challenge of loose stool and lactose intolerance during nasogastric or gastrostomy feeds. Do you consider for rice-based or alternative feeds or change in feeds concentration?
Okay, thank you for that question. So actually, in my practice, I've very, very rarely seen lactose intolerance. And of course, there are lactose-free feeds available in some countries as well. Rice-based, as in again whey-based, rice-based feeds can be considered. Soya-based milk can be considered, but the essential thing is anything that is not milk is likely to have a much lower calorie content, calcium content, and certainly protein content. So these factors need to be carefully thought through. And if you need to go on to some sort of an exclusion diet for your patient, then it's extremely important to keep in mind these other factors. Um, Certainly, as the child gets bigger, a variety of other pureed foods may also be considered.
Thank you, Rokshana. So Dr. Sadaf Asim is asking you how to manage hypoproteinemia, in children on PD and who have not reached weaning age.
Okay, that's again a very good question. And a protein loss into the peritoneal cavity is something that's common in children, especially in the babies, because babies have more large pores in their peritoneal membrane, and the protein and often also the sodium will leak out through this. So, what I would do is, as per the KDOKI recommendations, I would increase the protein allowance in the feed and increase it by an extra even so we would aim to give between 2 to 4 grams per kilo per day of protein in children on PD, keeping in mind that the urea levels have to be monitored. Now, prevention is always better rather than getting into a mess with this. So, in children, in my practice, when a child starts on PD, we would immediately be increasing their protein allowance from the start. It can be that controlling the serum albumin becomes quite tricky because the protein losses can be much higher, can be overwhelming, and you'd need to then think also and adjust your PD prescription in terms of whether you need multiple shorter cycles or whether this child can actually do with some longer, slower dialysis. Keeping in mind many of our babies are polyuric, so fluid requirement removal is not a big issue. But it is indeed an ongoing and challenging thing, which needs very careful monitoring.
Thank you. And every time you give an answer, actually received messages of people thanking you for your answer,
Thank you.
and I'm not repeating them, but just to let you know. So Dr. Akila Hassam is asking, how often do you face oral aversion syndrome in a child on gastrostomy feeds?
Very rarely, actually. And to be honest, much more often in children who have NG tubes, nasogastric tubes, rather than gastrostomy tubes. The gastrostomy tube I would consider it, and I would tell the families and the parents that this is supplemental. It is in addition to oral feeding. And all these sort of not so nice things, such as the medications, sometimes the extra fluid after transplant, and sometimes the feeds that we give the child, which are not very tasty, can be put through the tube. But we strongly encourage children to eat. So, in my practice, the oral aversion is far more common in the young infants and the babies who've been on tube feeding since birth, um, and have had renal failure from birth. Again, as an example of this, after transplantation, usually at the end of the first 2 years after transplant, we are able to remove the feeding tube. Sometimes what happens is the resistance to removing the tube comes from the families, and the parents have got so used to the tube and actually like it, and they don't want you to remove it because they feel we can give the medicines to the tube. The sort of daily struggle of trying to feed the child is not there, and it becomes much easier for them to manage their children at the medical care of their children at home.
I agree with you. I completely agree with you. So we have one more question from Dr. Sadaf Hassim. How to manage high phosphorus when you can't restrict milk intake in very young babies?
Okay, that is, I do a lot of research on phosphate, so it's one of my favorite questions. So clearly, what one would have to do with that is to use phosphate binders from an early stage. Now, sometimes we can use synthetic feed as well. So that means artificial feeds, which are renal feeds and low in phosphate and low in potassium. But if this is not available and you're using a milk-based feed, then calcium carbonate or calcium acetate can be used. And as I showed you in that graph from the IPPN, I can probably bring it back again. The IPPN graph showed really nicely that it is really not so much the issues with the child's phosphate level as infants, but it is something that becomes much more of an issue in older children. So if you can see this graph on my slide, you will see that in the IPPN registry, the infants have only 6% of infants have hyperphosphatemia. So it is not really a matter of controlling the feed, which is such a difficult issue. It's just giving adequate binders. In the teenage patients, on the other hand, here 80% of teenagers, most probably because of poor compliance or because of eating a lot of Western diet, processed foods, um, and non-compliance with binders have very high phosphate levels.
Okay, okay. Well, I see maybe one last question that could be useful for the audience, Rukshana.
So,
Uh, when is too much vitamin D?
when is
What
it
is
too?
your, when do you think that when do you think that we're giving too much vitamin D? What is your, what parameters do you follow to monitor an excess supplementation of vitamin D?
Sure.
What would make you decrease the amount of vitamin D in a child on dialysis?
Sure. So, as per our ESPN recommendation, and it's available free on the ESPN website, we have recommended to keep levels of 25 hydroxy vitamin D above 75 nanomoles per liter, or 30 nanograms per mil, whichever unit you use. So, we aim for those levels, and we would provide supplementation, and we provided a table in these guidelines to suggest what range of supplements are required, what doses are required to keep the levels above 75. Certainly levels above 150, I would stop supplementation absolutely by levels of 120 or 150. But in practice, vitamin D has a very, very wide therapeutic index. So levels less than even 250 are thought to be safe. There can be a risk of nephrocalcinosis, particularly in patients who have like all our CKD patients with a poor tubular function. But otherwise, vitamin D has a very wide therapeutic range.
Okay, actually, the purpose of the question was actually to make you actually cite this recommendation, which I honestly think are extremely useful, and I would invite everybody to listen to read them carefully. Well, there are no more questions, so again, Rukshana, thank you very, very much for this wonderful talk, and thank you everybody for your participation in this webinar. Thank you very much.
Thank you, Francesco, and thank you, colleagues.
Bye.
Bye-bye. Bye.